again. Actually, Dr. Howard doesn't need any introduction. The reason is because he has been to this platform 2 times before. But for those who are watching this session for the first time or listening Dr. Howard for the first time, Dr. Howard practices at Nemours Children's Hospital, which was previously known as Alfred DuPont Hospital, a very famous hospital in USA. He completed his medical training in Canada, and then he got trained at Royal Children's Hospital, Melbourne, followed by a fellowship at Starship Children's Hospital in Auckland. Dr. Howard also obtained a training on hip preservation from Professor Gans, and he has also written a wonderful book, Pediatric and Adolescent Hip Problem, which really cover almost every topic related to hip issues in this age group, with lot of figures, lot of surgical techniques, and I would strongly recommend the fellows to read this book. In addition to medical training, Dr. Howard also holds a bachelor degree in electrical engineering. I don't know how far or how come he's using that knowledge in the orthopedic practice, but fine, that's really wonderful, and that's like the wide experience he has other than orthopedics. Today, Dr. Howard is going to speak on orthopedic management of muscular dystrophy. This topic is very uncommonly discussed at meetings. I rarely have seen this topic being discussed at national level meetings. And again, the literature is also very sparse on this topic. And considering these two things, this lecture or this session is going to be very useful to all of us, because he's going to enlighten us about the management principle, and he's also going to emphasize how these principles differ from the management of other neuromuscular condition. Before I hand over to Dr. Howard, I would like to thank OrthoTV, who is kind enough to support this academic activity. And without any charge, without any expectation, they are strongly supporting this academic activity. So my sincere appreciation and gratitude to OrthoTV. And with that, I request Dr. Howard to share his experience. Over to you, sir. Thank you.
Thank you so much, Dr. Gandwala. It is my absolute pleasure to do this talk this morning. This is an area where I am very passionate about this. As you said, it's an under reported area, and it has not had the spotlight on it that some of the other neuromuscular conditions have had, like CP and more recently spinal muscular atrophy. But I think we're going to see this muscular dystrophy come more into our orthopedic spotlight over the next number of years. Certainly it is even at this point, as we get into an era of more gene replacement therapies and gene modifying therapies that happens in Duchenne. Some of these treatments I never thought I'd see in my orthopedic lifetime, but here they are, and we'll talk a little bit about that. So hope you get something out of this. I wanted to start with a case. So this is a 7-year-old male who complains of falling and tiring easily. He walked at 18 months, so still within the normal range, but 6 months later than his brother, according to his parents. He had a normal birth history otherwise, but has been a toe walker from about age 3 to 4. He was started to have some trouble climbing the ladder at the playground at around 4 years of age, and his relatives say that he walks funny. As he's gotten into school age, his teachers have noticed that he's had poor concentration. And here he is walking in the clinic. You can see he's kind of got a wide-based gait. His arms are also spread out for balance. And he has a little bit of an early heel rise. And if you look closely, as he walks past you, you see he's got some equinus there. His calves look a little big. And here he is getting up from the floor with a Gower test. See, he has a little bit of trouble with that. He has to use his hands to push himself up into extension. And that's a Gower sign suggestive of hip extensor proximal muscle weakness. Closer look at his calves show that they're quite generous with some calf pseudohypertrophy. And if you look at his spine and pelvis and the sagittal plane, you can see he has a lumbar lordosis, anterior pelvic tilt, which is associated with hip extensor weakness. This child had some laboratory tests, which had a very high creatine kinase level of 4,500, can be even higher than this in some cases. Usually it's up to about 140. DNA analysis showed a mutation on the short arm of the X chromosome coding for the DMD gene with a gene product called dystrophin. And so this child has Duchenne muscular dystrophy. And this is the most common muscular dystrophy. And most pediatric orthopedic surgeons are going to see this at one point in their career, at least one point. And if you're like me with a special interest in neuromuscular conditions, you see it every week. This is 1 in 3,500 live births, and it's X-linked recessive. So it's primarily seen in males, although you can rarely see it in females who have Turner syndrome. Dystrophin is the gene product, which is the problem, encoded by the DMD gene. And that gene is the largest in the human genome. Dystrophin itself is a cell membrane, muscle cell membrane stabilizer. So when dystrophin is affected, the cell membrane is more susceptible to muscle damage, which leads to inflammation. And of course, like any tissue in the body, except for bone, inflammation leads to scar tissue or fibrofatty replacement. And over time, those muscles get replaced with fibrous and fatty tissue, which leads to muscle weakness and muscle contracture. As you can see here in this histologic slide here, which shows some more hypertrophied muscle fibers interspersed with fat and fibrous tissue. This is you can see up in the corner here, the dystrophin molecule, how it sort of how it's involved in the chain between actin to the connecting between actin and the muscle cell membrane through the dystroglycan glycoprotein complex, which is this whole entity here. And that complex connects to the extracellular matrix and anchors the myofiber there and has some associations with myofiber remodeling. So not only does the muscle cell membrane become more susceptible to injury, but also the myofiber remodeling and growth is also affected. Dystrophin is an important part in this chain. So if that link in the chain is broken, then the whole thing falls down. It's a very large protein, as I talked to you about, and the mRNA strand that encodes it is incredibly large, and that has an implication for the delay in gene therapy. The gene was so big that we couldn't fit it into the viral vector required to deliver it to the cells. But there's been some recent developments which have really changed that paradigm. You have also heard, I'm sure, about Becker muscular dystrophy, which also is a muscular dystrophy associated with weakness, though to a much less severe functional phenotype than Duchenne. So Becker maintains its ambulatory function at least until the later decades, and lifespan is also relatively preserved. It does also involve deletions in the DMD gene, but the reading frame of the mRNA is preserved. So even though there's some deletions, a dystrophin can be made, which is abnormal, but still has some function. In Duchenne, the deletion disrupts the reading frame of the mRNA, and so there's no dystrophin made. And so that's why you have a much more severe phenotype. But the protein is resilient. And when you have this functional dystrophin, despite having these large deletions that you see in Becker, that gave some ideas to, the scientists looking at dystrophin to say, hey, maybe we can use that idea to say we don't need all of that dystrophin molecule. Maybe we can make a smaller one. And so it's also the basis for exon skipping therapies, as I'll talk about. Clinical presentation of Duchenne muscular dystrophy, you typically see a delay in motor milestones, but it's fairly mild. So you might not know the child has muscular dystrophy until the ages of about 3 or 4. They typically present with some toe walking and the calf pseudohypertrophy, like you saw in our friend earlier, and early proximal muscle weakness. Their endurance is affected in things like climbing up a slide ladder, as you can see this child here. Frequent falls are the things that parents complain about when we're making this diagnosis. And without any kind of treatments, they usually stop walking about age 9. And that's also about the time you start to develop scoliosis. For Becker muscular dystrophy, there's similar things happening, but much less severe and at a much slower rate of weakness. Physical examination, you can break it into ambulatory, kids who are still ambulatory, and those are non-ambulatory. For those who are ambulatory, you want to look at their gait. And you saw this child had an abductor lurch. He had that waddle, the lumbar lordosis, had ankle equinus, and some children develop equinovarus as well. The Gower test tests for proximal muscle weakness, particularly hip extensor weakness. That's positive in these cases. You do have to look at the spine. I know a lot of you don't do much spine surgery, but it's important as a pediatric orthopedic surgeon seeing these patients to be aware of issues relating to the spine and to do spine surveillance and to make sure you know when to refer these children to a spine surgeon. So you want to look at them in the erect position. You're looking for signs of a scoliosis and particularly for those who are on steroids, you might get some vertebral fractures. And so you're looking for tenderness for those who complain of back pain. You're looking at the lower extremity for contractures at the calf muscle with the silver scale test, hamstrings, popliteal angle, probably less important there. Ober's test, looking at the iliotibial band, and I'll show you that test a little bit later. And Thomas test, looking for hip flexion contractures. You want to do muscle strength testing in these kids for the upper and lower limbs for all the major muscle groups. And you want to follow that over time to see how they're either responding to medications, if they are on medications, or how the disease is progressing. And that can help you determine any timing of interventions you might need to do. For those kids who are non-ambulatory, again, you want to look at the spine. You're always looking at the spine, checking for scoliosis development. And once you see that, you start to do your x-rays. You're looking for contractures, even though the children are not, for those children who are non-ambulatory, equinus and especially equinovarus contractures can really affect your wheelchair foot plate placement. We'll show you some examples of that. You want to assess the hip for painful range of motion, for the adduction rather than abduction range. So in spastic disorders like cerebral palsy, your adductors are the problems, with scissoring giving you functional deficits and associated with the hip instability. But in Duchenne muscular dystrophy, it is the abductors, usually the tensor fascia lata, which is the major problem, and that can affect wheelchair sitting as well. You want to look at their wheelchair, see if they have a good fit, make sure they have a good seating system. Sometimes you can get a piriformis syndrome, which can cause some leg pain with poor seating. Upper limb function is also very important. A lot of times, the kids will have proximal muscle weakness, but they can bring their, bend their spine to bring their mouth down to an elevated tray, for example, and still feed themselves. But after you straighten their spine, that may be a problem, and they might need other adjuncts to help them with that. Here's looking for proximal muscle weakness in a child with a congenital muscular dystrophy, actually, not Duchenne. But you can see as I lift her up off the bed there under her axilla, she kind of slips through my hands, and I really had to stop her from sliding all the way through. That just shows you her proximal muscle weakness at the shoulders. That's called a Marian sign. So let's talk about some treatments. The most important advance for Duchenne muscular dystrophy, I would say, is the introduction of steroids, which serve to reduce and affect that inflammatory cascade and thus improve function. It's the current standard of care for Duchenne muscular dystrophy. It was first investigated by Drachman in 1974, showed us a positive functional benefit in a small case series. But it wasn't until 1991 where prednisone was really shown to have a short-term improvement. Jerry Mendel. And in 1994, a derivative of prednisone, deflazacort, was also shown to be equally good in improving function. And the function that was shown to be improved was not only a delayed cessation of walking, but also improved pulmonary and cardiac function. That's so important in these kids where, their muscle weakness also extends to the cardiac muscle and the respiratory muscles. And that's their main limitation on their lifespan. In 2012, Bigger from the University of Toronto showed decreased scoliosis risk with deflazacort. At that point, they said that deflazacort basically eliminated the risk of scoliosis. We learned later with longer follow-up that it didn't quite do that, but did decrease it by about 60%. But the problem with steroids, even though they do reduce the amount of muscle involvement in Duchenne muscular dystrophy and do preserve function, the disease is still progressive. And there are also side effects with it, including weight gain, height loss, and cataracts. But the mood changes that can be associated with some children are the most common reason to stop steroids, despite the functional gains that parents know about. The just changes in mood are just too harsh on their quality of life. There's a newer steroid called vamorolone, which was just approved through the FDA, which has less of these side effects and some good functional improvement in early studies, but we need to see some more data on that. Another medical treatment, which is really exciting, and this is only something that really came on the scene, I think the first one in 2020 for FDA approval with exon 51 skipping, were these exon skipping drugs. So, if you see down here, here's if you can see my cursor there, the top sort of row of exons there, you say 48, 50, 48, 49, 50. That's a normal dystrophin pre-mRNA strand, which can make a normal dystrophin molecule. But in the next line down, you see if there's a deletion. And in the case of Duchenne muscular dystrophy, that deletion causes a disruption in the reading frame. And so you can't make dystrophin. But if you can somehow skip out on that exon 51 in this case, so that you can kind of jump over it, then you can still make a functional dystrophin. And that's the premise of these exon skipping drugs. And currently we have them available to skip exons 51, 53, 2 for 53, and 1 for 45 for the DMD gene. And these have shown to improve dystrophin levels within the muscle and now some secondary outcomes as well, including strength and function, like time to stand up. So we're still in early phases of these studies, and I can't tell you right now what the impact on our orthopedic manifestations will be, but I can tell you that there's a definite improvement in their motor function, things like stair climbing and preservation of walking, but I don't think the reduction in contractures is as robust as we would like it to be. So, as is usually the case, these drugs often improve function and their medical comorbidities, but the orthopedic manifestations are still there, which means there's going to be more work for us to do. So it's important to kind of get your head around this diagnosis again, because I think you're going to see them more often in the coming years in your clinic as these drugs are rolled out across the world. The most exciting thing, I think, right now in neuromuscular disease is microdystrophin. And this is the first FDA-approved gene therapy for Duchenne muscular dystrophy. As I told you before, the DMD gene has been known for a long time, but it's so large that it couldn't fit into our viral vector we have to deliver these gene therapies to the cells. But from our knowledge from Becker muscular dystrophy, where deletions in the DMD gene still made a fairly functional dystrophin, groups in the United States and in the UK, I think mainly had looked at editing the DMD gene, taking out those redundant pieces of it, and putting things together into a smaller microdystrophin, which can fit into the viral capsid, as you see this green cartoon here. And so that microgene, that microdystrophin, although it's not the whole normal dystrophin, is still functional enough so that the dystrophin that's made still has a positive effect. And if you look at some of the early trials on this, you can see this is the functional improvement of microdystrophin on the top versus controls with the North Star Ambulatory Assessment, which is basically a functional measure for Duchenne muscular dystrophy. So a huge functional improvement seen with microdystrophin. So that's really exciting. And this drug really, it only got approved just 2 months ago. So very early stages. But we have patients who've been on it through the early trials. So I've seen the results of this through our trial patients. So maybe a little bit of a sneak peek at what is to come. And it's currently indicated for kids with ambulatory CP in ages 4 to 5 years. And that indication is pretty conservative at this point, but it should expand in the future. But the impact on our orthopedic outcomes are unknown. But I expect they're probably going to go the way of some of the other gene replacement therapies, like in spinal muscular atrophy, where functional improvements happen, but the orthopedic problems remain. We'll see. But I want to show you some effects. So here's our first friend who was on deflazacort, so steroid alone. He's at 7 years of age, so still pretty young, but you can see he's pretty weak in these hip extensors. Compare that to an older child, 11 and a half, who was also on deflazacort, but at age 4 received microdystrophin therapy. And look at the difference in how he can get up off the floor. It's a lot faster. He didn't have to use his, that's a negative Gower sign. He didn't have to use his hands at all. And here he is down the hallway. He still has some equinus. You can kind of see that his heel doesn't quite get hit the ground. But he's so fast. He can climb up the stairs without using a rail. His mood is good. He's a happy kid. He mostly keeps up with his peers. So, a child normally at this age without any treatment at all would be in a wheelchair, would have stopped walking, and would have a significant scoliosis that might already have had surgery. So, the medical management of this disease has really changed the phenotype. And we want to avoid, the cardiopulmonary problems that are associated. These are very important for the orthopedic surgeon to know about. If you're planning any kind of surgery, maybe you're planning to fix their feet, maybe you're planning to fix their spine, or maybe their hip is unstable and causing them pain, you need to fix that. Before you do that, you got to check out their pulmonary function. Without treatment, without medical treatment, usually the pulmonary function decline is very rapid. And by age 9, it's tending to decrease by about 5 to 10% per year. Cardiac problems are also very prevalent, though tend to happen a little later, with a left ventricular failure in the early 20s from dilated cardiomyopathy. And this is usually asymptomatic until later. But, with steroid treatments, both of these aspects have improved dramatically, so that, the kids are living much longer. Instead of their early 20s, they're living into their early 30s and sometimes to mid 30s. And that's going to change even more with all of these gene therapies on the horizon. So what a difference from the time I started seeing these patients 20 years ago until today. I mean, it's just so exciting. Finally, we're to some orthopedic manifestations. Thanks for sticking with me to this point. I think it's important for you to know the landscape of the therapies that are available. But these are the 4 areas which I think are important from an orthopedic point of view. So the spine, I put number 1 because scoliosis is one of the most common things that orthopedic surgeons have to deal with. And not only scoliosis, but also vertebral fractures, which have a higher incidence with steroid use, which increases the osteopenia associated. Foot deformities, for those who saw my foot neuromuscular talk a number of months ago, we've talked a little bit about that in muscular dystrophy there, and we'll go into a little bit more here today. But equinus, equinovarus contractures are pretty well ubiquitous. But for the hip, flexion, abduction, external rotation contractures, subluxation, dislocation, the knee, hamstring, and knee capsular contractures can can cause problems, particularly with wheelchair sitting. Here's a child who is 13 years of age, had no steroids. You can see he's in a wheelchair. He's got a big curve there, looks to be about 40, 50 degrees. He underwent a scoliosis surgery. This is the old style. This was from early in my practice, probably from about 2006, where I was still using Lukey wires and unit rods and still very tried and true, works pretty well. This child stopped walking at age 10. Pulmonary function test at this time had forced vital capacity 30%, mild right ventricular hypertrophy, but he died at age 20 years of age from respiratory failure. And the scoliosis surgery really didn't have a big impact on that. Traditionally, we treated scoliosis early. And it's important to know about this. I know most people don't do spine surgery, but please don't tune out, because it's your job to pick this up and get timely management of this curve with a spine surgeon if it's not yourself. So but traditionally, when the curves were very small, we used to have to do x-rays every 6 to 12 months all the time, because we were trying to pick up a very small curve, about 20 to 25 degrees. And that usually started once they stopped walking. And we would do scoliosis surgery that early because we wanted to do it before the cardiopulmonary function declined too much. Since steroids came on the scene, and that has improved pulmonary function and cardiac function, improved lifespan, and also decreased the risk of curve progression or even the development of scoliosis, we've been waiting longer to do these type of surgeries, because in many cases, like this kid who's 21, got this small curve about 35 degrees, this has remained stable for 5 years. And he never needed any scoliosis surgery. So, steroids have changed the game. So the role of this early surgery has really been called into question. Although if you look in the textbooks and some of the consensus papers, they'll still suggest this 20 to 30 degree threshold, which I think needs to be reevaluated. Scoliosis surgery for Duchenne muscular dystrophy is important for wheelchair sitting. These children are eventually will be wheelchair ambulators, and their quality of life will depend on having good sitting. And scoliosis can really mess that up. In the early stages, when it's flexible, they do pretty well. But when it gets quite large and the curve gets extremely stiff, wheelchair sitting becomes a real problem. And you don't want to treat this late, so you need to send them at the right time. Our goal is a balanced spine over a level pelvis, but you have to be, honest with your patient and also with yourself that this does not reliably improve pulmonary function or survival. This is from a Cochrane review done on scoliosis surgery for DMD. There's high perioperative risk, much higher than for CP, 38% Duchenne versus 18% of CP. So you need to be ready for that and prepare. And the combination of that stiff, straight spine and upper limb weakness, as we talked about, can really affect patients' function, especially to feed themselves after spinal fusion, where now they're stiff in an upright seating position. Their seating's great, but they can't lift their hand to their mouth anymore or bring their mouth to their hand. Then that can really affect their independence. You need to be ready for that. In Wilmington here at DuPont, we have developed a system called the Wilmington Robotic Exoskeleton, which is basically a 3D printed bunch of plastic pieces and pulleys and levers, which takes away gravity, the influence of gravity on the upper limbs. So you don't need a lot of muscle strength to be able to lift your hand. So those kids who have spine surgery, I often have them see our occupational therapists and biomedical engineer to get them fitted for this REX machine, which is very simple and cheap to make. And I think the parts are freely available. So if you want to do it yourself, you can certainly do that in India without a big expense. And it's a really good way to keep kids' upper limb function working. I have some of my kids who use it to play piano and do things that they wouldn't be able to otherwise do based on their muscle weakness around their proximal upper limb. And I'm going to skip through this, but the main thing about scoliosis operative readiness is you have to make sure these kids see all the right people, pulmonologists, cardiologists, and they need to have stress dosing of any time you do any kind of surgery. These kids have adrenal suppression from their steroids, so you must make sure you do stress dosing perioperatively, or else you can run into some serious problems and even cardiac arrest after these type of surgeries. So please don't forget that and talk to your anesthesiologist about it. We did some studies looking at, scoliosis surgery, whether you do it early or late. I won't belabor it, but basically we found that if you do scoliosis surgery early, your risk of complications is no better than if you do it late. And probably it's mostly because of steroids improving their function, but also better critical care and medical management of comorbidities than we had in the past. And you can fix these kids any way you like. This is the older type technique with the Lukey wires, or you can use pedicle screws. Really doesn't matter. You get a little better correction and maybe less blood loss with the pedicle screws. But you can talk to your spine surgeons about that and see what they are doing. Certainly you want to make sure you send these patients to somebody who has experience in muscular dystrophy, because it is not the same as idiopathic scoliosis, and it's not even the same as doing cerebral palsy nor muscular scoliosis. It needs a lot more attention. Let's get to the foot. So here's a child I just saw in clinic, actually on Monday. He's an 8-year-old with Duchenne. He's got equine varus foot deformity, as you can see. He was walking really well up until about a month ago, and then he had frequent falls, became very fearful of walking. And you can see when he's way up on his tiptoes, he has a very narrow base of support. And so when you have proximal muscle weakness and your balance muscles around your trunk and pelvic girdle that are affected, I mean, you're gonna end up falling. So at this stage, this is a stage where you say, well, perhaps some carefully done surgery, which lengthens the calf muscle in zone 2, which is not a tendo-Achilles lengthening, but more within the calf itself, can preserve ambulation for 1 to 1.5 years. There's only been a couple of papers that have suggested this. In my own practice, I would say that this does happen, but you have to do things at the right time, and you have to make sure that you don't overdo the surgery. So your goal is not to get that heel on the ground. Your goal is to get the heel closer to the ground, increase the amount of foot contact with the ground without disrupting that plantar flexion knee extension couple. Remember, they have poor quadriceps function, so you need to have that tightness in your calf to push the knee back into stable extension, or else these kids, you'll just accelerate their progression to a non-walking stage of their disease. So, just be very careful. This child, I took this video about November, and I saw him on Monday for discussion about the upcoming surgery. I tried to get him in as quick as I could. But in that 6 months, he actually stopped walking. So, was it because we didn't get to it in time? Well, maybe he wouldn't have been walking anyways, and we should have been on this a little earlier. So when you see kids like this, you really should act as quickly as possible to not lose that window. So we're still going to do the surgery, but we're going to wait a couple more years and let them get a bit bigger, and then do it mainly for wheelchair foot plate placement and to prevent painful equine varus deformities. So speaking of that, equine varus, there's not great prevalence studies in the literature, but in my practice, it happens about 1/3 of kids with Duchenne muscular dystrophy, with the remainders being pure equinus. It's because your tibialis posterior typically has preserved strength, as does your plantar flexors until the last. These initially flexible deformities can become very rigid over time, and they can impede ambulation, as we talked about with our friend on the previous slide. But for non-ambulators, is also important. those foot deformities can get to the point where they can't wear typical shoes, which can be a problem from a teenage point of view. People want to wear nice shoes just like other kids, but in cold climates, like, you know, I'm from Canada, if you can't wear a pair of winter boots, that's a problem for you. Maybe not such a problem in India, except for maybe in the northern parts. You can get pain from pressure at the wheelchair foot plates. You can see this child can't even put his foot on the foot plate. It's really coming off the side. And, you know, so the goal of foot correction is really get a plantar grade foot that fits well on the foot plates, allows for shoe wear. Here's a person who, you know, who is coming up for surgery with me. I tried to get him to do surgery a number of years ago, but he said, oh, everything's fine. I don't want to do it. You know, they're a bit scared of surgery, whatnot. But now he's having pressure ulceration. He's had an infection, which we recently had to get cleared up. And so he came back really begging me to do the surgery. He's now 18 years of age, and that foot is so stiff. Instead of doing simple tendon releases or transfers, now I have to do some bony procedures, including even like a triple type arthrodesis or other osteotomies. So you don't want to be doing that, especially in very, very soft bone that you have in these kids. But here's your goal, 18-year-old here, pre-op, tendon Achilles ligament tib post transfer, complete to the lateral cuneiform. You see we've got a plantar grade foot. This kid's pain went away, his pressure areas went away, and he can wear his beautiful new sneakers that he is enjoying. So in a non-ambulator with equinovarus, you want to do the tendon Achilles lengthening first. That's a typical Z lengthening, as you can see here. This is just from last week, a child I did this on. And these are some pictures that were from my other talk, which if you've been there, you already saw these, but basically going to do release the tibialis posterior at the navicular, deliver it into your proximal wound posterior medially, sneak it behind the tibia through the interosseous membrane and out through the dorsum of the foot and deliver it down over the lateral cuneiform and through a drill hole, tie it over a button, and then you've got a plantar grade foot. We talked about this a lot. Darren and I had chatted over email about how to make that tendon longer, because often the tib post is not long enough to really do the transfer. So the way that you can do that is just split it and into a half and then just flip it down. As you can see here, this is from my friend last week. We actually have too much tendon now, and I needed to trim this a little bit, or else I won't be able to tension it enough. So trim that, and you can see we reinforce it at the where the split was to make sure it doesn't come apart, and that works out really great. So it's a good little technique. Let's get into the hip. You know, we're getting to the end of this now. You know, unlike in CP where you've got scissoring, or even in spinal muscular atrophy, mostly have adduction contractures. In Duchenne, we have abductor, external rotation, and hip flexor contractures. They typically take a frog-like position. They often sleep supine, and their legs are flopped out to the side. Over time, those muscles get contracted. And you can identify a hip flexion contraction from the Thomas test, but from the to look at your abduction contractions, I use the Ober test. I'm going to show you how that works here. You got kid with the affected, the one you want to test is up. You extend the knee and the hip, and then you let it fall down into adduction. If you have a contracture, it won't adduct. And so you know that you've got an abduction contraction. Sometimes it doesn't even adduct to the midline. And so if you got really severe contractures, that can affect your wheelchair sitting, and you might need to do some muscle lengthenings. But unlike in other neuromuscular conditions like cerebral palsy, the flexor the flexion contracture typically comes from the sartorius, rectus, and tensor fasciae lata. Fascia lata also causes the abduction. And so when we have kids who have such severe abducted hips such that they can't fit in their wheelchair, and sometimes these contractions can also affect their sleep positioning and cause pain. In those cases, we do a muscle release, a fractional lengthening of the tensor fasciae lata, which you can see here, and also complete release of the sartorius and rectus. And then if the iliopsoas is tight, then you can go after that, but usually you don't have to. Usually you got what you need from that. So different than CP. The other thing is these hips do become unstable. I just saw my friend yesterday who was 6 years old, actually, is 7 years old, on Monday in the muscle clinic. And I was examining him, and his hip was clunking in and out of the joint, but he was smiling. He was happy. It didn't hurt him. And I told the parents about it. And I said, well, if it hurts him, we will do some x-rays and do something about it. But if it doesn't hurt him, then there's nothing to be done. But here's a 16-year-old with Duchenne muscular dystrophy whose hip was going in and out of the joint. But unlike that younger child, did develop some pain and really wanted something done about it. It was affecting him in his sitting, affecting his sleep. And every time that hip popped in and out, it gave him pain. So we did do a reconstruction, which you could say pretty similar to what we do in CP, for example, varus derotational osteotomy. We didn't have to do any soft tissue releases in this case. We did a high dose acetabuloplasty, like a DEGA style. But you can see these bones are very osteopenic. So you have to be careful. Sometimes you need to pre-treat them with bisphosphonates. In this case, we did okay and looked great. His pain was relieved. He was super happy. But we do this in a reactive way. So we're not, unlike in CP, where we're more proactive because we know the natural history is typically for painful arthritis. In muscular dystrophy, a lot of the times this hip instability can be completely asymptomatic. So we only do this type of procedure if they are having functional problems or pain. Because also, unlike CP, they have a very high risk of recurrent hip subluxation as the disease progresses, as these muscles, the abductor muscle in particular, gets weaker and weaker. There's nothing really to hold the ball in the socket. And so here's the same kid who, despite all our best efforts, and nice early x-rays 2 years post-op, had a recurrent hip dislocation. But thankfully, he is not having any pain. So he's still actually happy. But, I would say just be cautious about doing this. Be reactive. Look at all the other alternatives before going forward with hip reconstruction, and do the highest dose hip reconstruction you can, anticipating that the risk of subluxation is high. You see, he also had some spine surgery in the interim, which, helped him with his seating. So he's kind of done with me now, which he's happy about. Just talk a little bit more about the spine. In addition to scoliosis, these kids are on steroids. Even without steroids, they have significant osteopenia. They are prone to vertebral compression fractures. So whenever these kids, always ask them if they have back pain or other lower extremity pain, because they can get fractures in other places. But if they have back pain, get a lateral x-ray. It is a standard now for these kids to do after a certain age. I can't remember the exact age, to be honest, but to get a lateral x-ray to check for this on a yearly basis. And if they're having these type of fractures, you won't want to get a bone density scan and treat them with vitamin D or bisphosphonates. But usually these are non-surgically treated. These are treated medically, and identification is the orthopedic surgeon's role. Lower extremity fractures are relatively common. In non-ambulatory kids, the distal femur is the most common fracture that we see. And as you can see here, usually metaphyseal, it's an insufficiency fracture. If you're non-ambulatory, a brief period, about 3 weeks of soft immobilization, I usually use like a knee immobilizer for that, not a cast. The cast will exacerbate that bone demineralization and set them up for recurrent fractures. So cast is not the right idea. Brief immobilization. But if they're that's for the non-ambulatory or not walking. But if they're ambulatory, you need to make sure that you do everything you can to get them up. You don't want them to stay immobilized for even a few weeks, because that few weeks can cause them to have significant muscle atrophy, and they may not start walking again, depending on the time of which this happens, which is usually around that transition. So if they're ambulatory, you want to treat these with, more operative fixation, which can achieve early, immediate weight bearing. Particularly in case, in this case with a metaphyseal fracture, there's been some reports of using elastic nails that come up through the epiphysis across the physis. on both sides in a cross fashion, like we would do in a, a younger patient with a femoral shaft fracture that was length stable. And that has allowed patients to get up with some other, like a neomobilizer type immobilization. And so that's one way to get them up if they're still ambulatory with these distal fractures. If it's more femoral shaft fracture, like this child here is a 14-year-old who was on deflazacort, has ambulatory Duchenne muscular dystrophy, tripped. He's got pretty significant equinus, tripped and had this femur fracture. This is the type of thing that could stop this kid's walking forever. So the goal is stable fixation, immediate weight bearing. In this case, this child was treated with a rigid intramedullary locked nail, and this kid was mobilized immediately. There was no non-weight bearing time for him. We got him up right away. We actually brought him in hospital for some inpatient rehab to make sure that he did not lose his walking function. Because after a fracture, about a lower extremity fracture, about 20 to 40% of ambulatory Duchenne muscular dystrophy will stop walking after fracture. So you need to try your best to avoid that sequelae. So we do hip surveillance, x-rays in other neuromuscular conditions, particularly CP, and we do spine surveillance, mostly clinical, and then radiographic surveillance. What do we do in Duchenne muscular dystrophy? For the spine, as I mentioned to you, you need to keep looking to find signs of scoliosis. Once you find some scoliosis, you do x-rays if you find a clinical detection of scoliosis. And then if that curve gets over about 40 to 50 degrees, then that curve should be operated on. And so you need to refer that to the right person. For hips, as I talked about, because usually these are non-painful, you'll be very reactive with your x-rays, meaning just get a hip x-ray if they're having pain. And then if they've got painful instability, you can do what I said to do, recognizing that they have a much higher risk of recurrence and complication rates than other neuromuscular conditions. So be reactive with hip surveillance. So in summary, it's an exciting time for Duchenne muscular dystrophy. You're going to start to see these kids come into your clinic more and more. Get yourself familiar with what's going on in the current landscape. I hope this is a good introduction or another reintroduction for many of you. The phenotype is changing with the introduction of gene modifying and replacement therapies. Steroids are still the mainstay of treatment, though, and we can expect improved function and decreased rates of scoliosis, though the contractures in the calf and hip displacement still seems to be happening. Foot deformities can affect function both in ambulatory and non-ambulatory, but the timing is important, and the goals are different for these two different functional levels. Hip instability can occur, but treatment should be reactive. Fractures are very common, especially the femur and vertebral fractures. Your goal is to maintain ambulation, minimize immobilization time. And scoliosis surgery is important for quality of life, but has less effect on lung function. Thank you very much, and hopefully I didn't take you too long. I think I'm just about 45 minutes, so happy to entertain any questions.
Yeah, thank you, Jason, for a complete comprehensive covering. I have a few questions. You have not mentioned about the knee deformity in this population. So you don't see the knee flexion problems in these patients?
We do actually. We do see, we see particularly hamstring contractures and knee flexion capsular contractures. But from a functional point of view, usually they are not a problem when you're in the ambulatory phase. I think that this, a calf contracture, the equinus we see, really puts a strong lever arm using that plantar flexion knee extension couple to keep that knee fairly straight when the kids are walking. And it's only after they get into the wheelchairs where the hamstring contractures and those knee capsular contractures become a problem. But most of the time, as long as you have extension of the knee to over 90 degrees, then a child can sit in a chair. It's for those patients who have more than a 90-degree hamstring contracture, or for, children who are having problems with positioning in the bed. Sometimes I've had some people ask me to loosen the hamstrings, and just because they can't get in a comfortable position for sleep. So it's more about positioning and those sorts of things. So it's more the non-ambulatory kid. So you're right, I should talk a little bit more about that, but it's very rare to have to do anything with the knee flexors, and that's why I didn't really focus on it.
Okay, then there are a few questions in the chat, so let's take one by one. The first is about the role of gene therapy on life expectancy. This is a question from Dr. Fahad from Pakistan, and he wants to understand about the role of gene therapy on life expectancy.
Thank you, Dr. Fahad. Thanks for coming. The short answer is we don't know at this point. The gene therapy has been approved based on a secondary measure, like what we call a surrogate marker. Basically, they looked at the development of the production of dystrophin. So microdystrophin does a good job at increasing the amount of functional dystrophin. And so by that, they feel that that will lead to functional improvements over time. It's not normal dystrophin. It's not normal dystrophin levels. It's the microdystrophin that's made is not completely normal. So you're not going to get a normal phenotype. But, as I showed you in that patient who had microdystrophin at age 4 and other patients like him, it's very similar that you see such amazing differences in their abilities compared to kids who just have had steroids, for example. So I can only imagine that, steroids has prolonged life, and medical care has prolonged life from death at the late teens, early 20s to now living to 30 to 35. I can only imagine that microdystrophin is going to make that even better. But we don't know yet. I still think, though, we're going to have a role to play, and even more of a role to play for kids who have gene therapies, who are going to be able to do more, live longer, but still have these functional impairments from contractures and scoliosis and hip problems.
Okay, then we have a question from Professor Thomas. Hi, Jason. Just wondering how often you have had to do zone 2 lengthening of gastroaponeurosis and tibialis posterior transfer to dorsum of foot.
I actually do it. I just did it last week. I probably do. Maybe I do it 3 to 4 times a year, maybe, somewhere around there. I'm the main person seeing kids with muscular dystrophies here at DuPont, and we have a large population. Like I said, I have a muscular dystrophy clinic every week. So, I'm actually finding kids are running to more and more problems with their feet, particularly when they're non-ambulatory, to be honest. And the traditional approach was to ignore it. The child's not walking, who cares? Just put a bunch of foam under their feet and they should be fine. But actual fact, just like that patient I showed to you with the ulceration, they are having pain. And usually by the time they have pain, it's late and very rigid. They're not as healthy as they were. And, I much rather sort these feet out early rather than later. And I am moving more to that. I'm offering that type of surgery earlier than I used to offer in the past because of, when you get older and you see more problems, you tend to go, well, why didn't I be more proactive on those things? When it's easier to do, the risks are less. So I'm doing it a lot more. But the literature, as as Dr. Ganjwala said, is not fantastic. There's only a few papers out there that even talk about doing this. So it's something that I think I need to do, and others be great to get more interested in that, so we really know the implications of our treatments and when we should do them.
Okay, just I had a confusion. If it's an early equinus, you do zone 2 surgery. And if it's a late case, then you do a formal Z lengthening. That's a zone 3 surgery. Is it right, or?
Yes, you're correct. And the reason for that is the dose of the surgery. So if you have a child, and typically when you're doing these surgeries, the kids are way up high on their toes. They have a very small base of support. They're, and they're falling. When you look at their contractures, they're typically somewhere between -40 to -60 degrees, like very severe contractures. But you don't want to, in that ambulatory patient, you don't want to bring them into 10 degrees of dorsiflexion. Because if you do that, and you can do that through an open tendo Achilles lengthening, if you do that, the ground reaction force on their foot is going to go behind the knee, and their knee is going to flex, and they're going to fall on the floor because they have no quadriceps function to hold them up. So your goal there is to get them from a very small base of support at the tip of the toes to improve their stability and stance by bringing the heel closer to the ground, but really not touching the ground, just so you have more of that foot contact to give better stability while keeping that ground reaction force in front of the knee to push that, the knee back into stable extension so that quadriceps doesn't have to work. So it doesn't matter if it's weak or not. So that's the key. And that's why I say in ambulatory kids, do not do a zone 3 tendo Achilles lengthening. You will put them off their feet. Do a zone 2, which won't do the job for you all the way. It'll get you to about -20, -10, and that should be your goal. You don't want to go any further than that. Keep some equinus there to preserve the plantar flexion knee extension couple. And then that's when you'll get your year to year and a half improved prolongation of ambulation. It doesn't always work, though, I will tell you. I have had some kids where, that was my hope. And I always tell them, there's a chance that this will not prevent you from going off your feet. But in those cases, it's interesting. The patients are still happy that we did it because, well, now my feet are nice on my wheelchair and I can wear shoes and all these things they couldn't do before, they can do it now. So I think it's a good operation for the equinovarus foot.
Okay, then there is a question. Have you ever sometimes come across a reverse deformity, like say you have done a equinovarus surgery for the equinovarus, and that has resulted into planovalgus?
No, I've not seen that. I have not seen that. I transfer the complete tendon. So, in a spastic disorder like CP, you would do a split transfer, but in muscle disorders, you do a complete tendon transfer through the interosseous membrane, and I put it through the lateral cuneiform. So it tends to evert the foot and prevent plantar flexion or help prevent recurrence. Some kids have active dorsiflexion too from this. And and I have not seen anybody go into planovalgus. Kids with Duchenne will have planovalgus though early on when they're young and they've got early equinus. You'll see that planovalgus happening in midfoot break. It usually doesn't stay. It usually converts itself into that equinovarus over time or pure equinus.
Okay, then we have a question from our friend from Bangladesh, Dr. Kaiser. Is there any way to differentiate between DMD and BMD in clinical setting without gene sequencing?
Well,
except age.
Yeah, I think what you'll see is, of course, if you don't have access to gene to a genetic diagnosis facility, simple CK laboratory test can tell you if there is a muscular dystrophy happening. In Duchenne muscular dystrophy, it's very high. It could be like 100 times normal, or 10 times normal, I meant to say. In even 100 times normal. In BMD, the increase is not as high, but it will still be high. So your CK will be high, and you'll see, things like development of equinus contractures. You'll see some issue like maybe a positive Gower that needs a single hand to push yourself up. So you'll see signs of proximal muscle weakness. You may or may not see calf pseudohypertrophy in a kid with Becker muscular dystrophy, and the functional phenotype is very heterogeneous with Becker. So, you can have a kid who's 18 and, one of the kids I follow, he's just turned 19. He's helping his father run his construction company. He's lugging around big blocks of concrete and stuff like this, and he can do all that. Just has some mild contractures and a little bit of weakness. And then other kids with Becker who have a severe scoliosis and are in a wheelchair at that point. So, it's the phenotype is different because the deletions are also heterogeneous in the Duchenne molecule, or sorry, in the DMD gene. So I would say CK and do your physical examination, look for proximal muscle weakness and contractures, and then how they progress. Beckers don't usually lose their walking function at age 9 to 10, but a kid who's not treated with Duchenne will.
Okay, then there is a question about the scoliosis surgery. Do you screen for the bone quality before the scoliosis surgery? And if yes, how does the result affect the management?
Yeah, that's a good point. I mean, these kids are often because they're taking steroids, they're often on a regular bone density measurement. They often get one on a yearly basis. So their vitamin D is being optimized. It's rare for us to put them on bisphosphonates, although occasionally they go on bisphosphonates. But to be honest, as a spine surgeon as well, scoliosis surgeon for neuromuscular, all of these kids have soft bone. And we anticipate that, but our implants are such that I think we can manage that even without using bisphosphonates. So I don't usually ask for bisphosphonates to happen. I'm more asking for bisphosphonates if they've had recurrent fractures, or painful vertebral compression fractures that are continuing. So that's the main reason I would do bisphosphonates, not so much for preparation for scoliosis surgery.
Okay, then one technical question. At what is the right age for equine surgery? When child is just stopped walking or is walking?
I think it depends on your goals. So if it's an ambulatory kid, then
yeah, for the walking function. Yes, for the walking function.
Yeah, so if that kid is getting around, they can be very high in their toes and still function very well and not fall and be stable and feel comfortable. It's only after they start to have some falls and start to get fearful of walking, which I think that's the sort of transition point where those with severe contractures, if you don't do anything at that point, they probably won't be walking long after that. So I think that's a time. And when they go way up on their tiptoes, but they're still going okay right now, that's when I start to have the discussion. Say, he's still doing well now, but just keep an eye. If you're seeing he's tripping more or becoming more fearful of walking, come in and see me right away. Let's talk about whether or not surgery is right for you. After they stop walking, there's no point. You're not going to get them back on their feet. So it's important to time it properly. And like the kid I showed in the presentation who was very close to not walking, probably we should have intervened earlier. Definitely we should have intervened earlier, and I might have got him another year to year and a half walking. His father basically, when he came to see me yesterday, he said, I don't see any point in doing that now. And he's doing well otherwise, but I do think that this will be beneficial for us in the future for his wheelchair. So let's talk about that in a couple of years. So that's the difference. And I can't give you an age because it depends on how the kids are treated. And it depends on the Duchenne phenotype is heterogeneous as well. Some kids are quite weak quite early, and others, their weakness doesn't occur till later. This is with kids usually who are the ones who are treated with steroids. So the response to steroid treatment and even some of these gene therapies is also variable. So, like I had a kid who was on deflazacort and he was still walking. He was 19 years old. And then he started to have problems with tripping and falling. And we did a calf lengthening at 19 years old. And that's the exception rather than the rule. But in his case, he wanted to keep walking. He wanted to give it a shot. And he did walk for another little bit. So yeah, so it's variable. I think you have to think about the patient and treat them all individually. I think we lost Darren. Let's see if we have anything else. I can read the chat here, I think. Did we get all of the questions? Thomas, you got your hand up.
I just wanted to ask Jason. See, we don't seem to see these kids in the second decade. We seem to see them in the first decade in India. Whether it's because of the lack of steroids or the lack of genetic diagnosis, by the time we see them in the first decade, they're already very weak. We hardly see them in the second decade to see all those problems of scoliosis or what you're talking about. So I'm just wondering, these newer drugs, which seem far away, I don't know when they will come to India, because in a low middle income country where we don't have access to the newer drugs and to those gene therapy, it looks like a dream for most of our patients. So I just wanted your thoughts on that.
Yeah, I mean, I agree with you. And I mean, these are all very new for me as well. I mean, I'm lucky I live in an area, even within this part of the country, you know, we have better access to these things than other parts of the United States and Canada.
Yeah.
But steroids are reasonably cheap, and it doesn't have to be deflazacort. Prednisone seems to work just as well, and that has been shown to improve ambulation, reduce risk of scoliosis, improve cardiopulmonary function, as I said. And it probably the reason why you're not seeing them is maybe a lot of these kids aren't getting that early diagnosis and early treatment. You know, we typically start steroids at about age 4, and that seems to work the best for them. So if they're not getting screened and picked up at that early age, and maybe they're not even diagnosed until later, or if they don't have that kind of people who are tuned into those diseases, then by the time you get they'll be untreated, they'll be natural history. And then basically you either treat them for scoliosis or there's nothing else for an orthopedic surgeon to do, right? Maybe the calf lengthening for wheelchair supports or whatnot, but I do see what you're saying completely. But I think it might mean that we just need to have a little more attention to these kids, and get earlier diagnosis and interventions. But it is difficult. I understand when you're talking about the challenges in India, and not only India. I would say most of the world's population is in the same boat.
The other thing you said is a small window of opportunity for us to do those calf lengthenings. I'm just wondering, we've never done that, thinking that if we do that, we'll maybe tip them over and not make them walk in the fear of that. So I'm just wondering whether we know when to do that exactly.
Yeah. And you know, the patients that I'm dealing with, of course, are patients who have, I mean, I would say 90% of our kids are at least treated with steroids. The ones that aren't are the ones that have had issues with the side effects. And so my population is very much a different phenotype than the natural history. So, you know, in a kid who's going to stop walking at age 9 to 10, you know, is that window truly there? Right? Maybe that window is way too short and there's not enough benefit for the risk. But I would say in the steroid patients that window is much wider. And I don't know what's going to be in exon skipping drugs and now the gene therapy, microdystrophin. I suspect it'll be an even larger window where we have longer time to sort of assess them and decide what's best for them. But by principles, with just steroid treatment, that window should be available. Thank you for that question, Thomas.
No problem. If Dhiren is not there, then maybe I should thank you on behalf of Dhiren and Kosi.
Who is there?
And then Oh, he's there, huh? Okay.
Came
Yeah,
back.
thank you, Jason. Like there was all of a sudden my computer got freeze. So thank you. This is going to be a very, very important session for all of us. Whenever we are going to manage a child with Duchenne's muscular dystrophy or any muscular dystrophy, we will be listening this lecture. We will be re-listening and clearing our concept about the management. So thank you once again for giving us overview about the management. And we will again have one more session about the new topic in which you are interested. So we are looking forward to have you with us once again. Thank you.
Okay, my pleasure. Thank you so much, and thanks to you all for coming.
Yeah. Thank you.
Thanks. Thanks, Jason. Nice to see you.
Great to see you, Atesh.
Yeah.
Thanks, everybody.
Bye.
Bye.